Over to you.
Thank you, Sri Priya. Good evening, everyone. Very warm welcome to the very first session of the 18th edition of Volunteer Training Program in Palliative Care. Today, as Sri Priya said, our first session will be on the introduction of palliative care. So basically, what exactly is palliative care, the myths of palliative care, the role of volunteers in palliative care. We look onto the holistic approach of volunteerism in palliative care. So today, I'm really proud to see that we have Dr. Rajagopal as our faculty, a very apt person to take this session. We don't need to introduce himself, but I'm supposed to do it formally. Dr. Rajagopal is the director of Trivandrum Institute of Palliative Sciences, which is a WHO collaborating center for training and policy assisted relief of pain. And he's the founder chairman of Pallium India. His initiative is to remove the regulatory barriers in availability of oral morphine for pain relief have contributed to the simplification of narcotic regulations in most of the states in India and the amendment of NDPS Act of India. He and his colleagues also contributed to the development of government policies in palliative care, which in numerous states, along with the Kerala in 2008 and Government of India's National Palliative Care Strategy in 2012. Named as one of the 30 most influential leaders in hospice and palliative medicine by American Academy of Hospice and Palliative Medicine 2017, Dr. Rajagopal was also honored Padma Shri in 2018 by Government of India. Really glad and proud to have you here, sir, in this session. We are looking forward to have a very interactive session. Over to you, sir.
Sri.
Yes, sir.
Vishnu and Sri Priya, thank you very much and welcome everybody. Everybody is not visible. Almost nobody is visible. Friends, I wish we were all sitting together in a room and talking to one another, interacting with your faces and your eyes. That's not possible because it's a virtual event. But this dark screen is so discouraging. At least let us see each other. Is there, I mean, I can understand if about 5 of you have a bandwidth issue, but when all 45 have blank screens, can you please switch on your videos?
Sir, video is on my side.
Oh, then it is a problem with me. Okay, let me see. If you will all be patient with me, can I log off and come back? There seems to be some problem.
Sure,
Sri
sir.
and Vishnu, okay?
Sure, sir, sure.
Sure, sir.
I see that Vishnu, Sunanda, any other regional coordinators here?
No, sir. Just both of us.
These are among the people who we hope will be able to work with you in future. What I mean to say is, okay, we have these few sessions and then we'll all go our separate ways, and then it shouldn't be the end of the collaboration. We hope to work with you. So please do feel free to come back to us, and I hope we can work together to reduce the burden of suffering in our country. Let me ask you a question. Sri Priya, how many sessions?
5 sessions in total, sir, we have.
And you said 80%.
18th edition, sir.
Sir, 80% attendance, we do focus on most of the programs.
Yeah, that means 4 sessions, right? Minimum.
Yes, sir. But in VTP, we have just liberalized 1 session in case, which is
so
not
you are,
approved.
I mean, I personally, I believe we are conveying a very wrong message with that.
Sure,
We
sir,
are dealing with something that is very important. When the purpose of the course is to interact with human beings and influence their lives, when we say, okay, 3 out of 5, 60%, Suppose you are missing the session on communication.
Yes, sir.
And
Thank you for
then
pointing out, sir.
actually our interventions will be actually counterproductive. It's easy to say something that with the good intentions without understanding the mental frame of the person. So maybe, Sri, sorry to bring this up now, but maybe we'll review that policy for the future.
Definitely, sir. Your word is final, sir. It would be 4 sessions itself.
Wait. No. What I say is a suggestion. It also has to be practical.
Yes.
So if somebody has missed a session or two, maybe we have to make the facility for them to do that at the next VTP, Volunteers Training Program. Okay. With that, sorry, second negative note. Hey, very bad. Sorry, Vishnu and Sri and everybody. I would request you now to answer a question for me. You will see the question. Apurva, I don't think we would have planned the next session yet, but certainly, Sri, there is a question from Apurva. We'll have to answer that question over a period of time. So, I thought I was the co-host. Will you enable my screen sharing again, Sri?
Yes, sir. Done.
Okay, thanks. So here's a question on the screen. Will you please write down your answer on the chat box? So quite a large number of answers, and thank you very much. Especially when you put a few together, that will mean an excellent description of palliative care. For example, Nikhila says it is relieving suffering. Yes, Nikhila, that's at the essence of it. At the essence of it, it is relief from serious health-related suffering. And naturally, Popsy, our concern for the person is at the root of it. It's about helping them, true, as somebody else said, to live with quality of life. It is certainly pain relief, but not only pain relief. Maybe, but maybe you do not necessarily mean physical pain. It may be psychological or social pain, or it may be other symptoms like breathlessness or something. And Apurva, yes, listening and understanding is so important. Listening at the crux of it. And we have to deal with people with empathy. Elena, what do you mean by empathy? Either you can unmute and speak, or you can put it upon the chat box. Elena, empathy is trying to place oneself in somebody else's shoes, trying to think from their point of view. That is empathy. And responding appropriately. That is when, if the person is looking totally confused, it is about sitting down beside that person, see the confusion in the face, and asking the person, hey, is there some problem? Is there something that you do not understand? That is empathy. Empathy is being there for the person. Well, that would be the next step, Elena. Empathy is trying to understand the problem from their point of view. But empathy without compassionate action would mean very little. Compassion and compassionate action is the next step. Empathy is trying to understand the problem from their point of view. Tarun, it does not have to be temporary. Whatever we are doing, we can aim for the duration of life. Sometimes we do succeed. And Vaishali and Sachin, true. People with terminal illness, nearing the end of life, may be rejected by many people and need our special attention. But Vaishali and Sachin, is palliative care only for terminally ill? Like
Sir, actually, this is what I can type as this fast only.
Yeah. Like everyone else, I have about 10% chance of dying from cancer someday. If I have cancer, I may have pain, maybe my first symptom. Do I not deserve treatment of pain at that time? I may be greatly psychologically wounded. I need support at that time. So I shouldn't be made to wait till the last few weeks of my life. So Vaishali and Sachin, while I agree that it is definitely necessary for the terminally ill, I would also equally importantly highlight that that is not enough. It should not be reserved only for terminal illness. And Talienla, sorry if I am mispronouncing your name, Talienla. You are absolutely right. It is about quality of life. Our aim is to improve the quality of life as much as possible. And of course, helping the distressed. Alina, absolutely. If we are to improve quality of life, doctors alone cannot do it, nurses alone cannot do it, social worker alone cannot do it, volunteers alone cannot do it. We all have to come together with a multidisciplinary approach, working together. Interestingly, Alina has put in the word cloak there, C-L-O-A-K. You know, something that is a covering for the body. The word palliative care, as Alina points out, comes from the word pallium. Pallium means a cloak or C-L-O-A-K, okay, cloak or covering. So the disease may still be there, but we are providing a cloak of comfort. That's what it means. Dr. Jail, sorry, not doctors. Aishi, yes, reduce pain, but as I said, not only pain. Jacob Kurian, yes, patient care. But now that you mentioned patient care, I must say, along with the patient, the whole family suffers, right? So actually, by definition, palliative care is for the patient and family. I'll avoid the comments already made. It includes rehabilitation, absolutely. Any healthcare has to include rehabilitation, and we do concentrate on that quite a lot. I'm just going through all the answers. Alina, you say from the time of diagnosis for all life-limiting diseases. Again, from the time of diagnosis, a part of the official definition. A footnote says from the time of diagnosis. But that's fine. Okay, official wording. But Alina, let me ask you. If I am coming to hospital with agonizing pain, you may take weeks to make a diagnosis, X-rays, CT scan appointment next week, then an CT guided biopsy. By waiting for the biopsy result, why should I have to suffer? Personal feeling is nothing official about this, but my personal feeling is relief from suffering has to start when the suffering starts. And as I am scrolling down the faces in front of me, I see Stella. Hey, Stella, what are you doing here? Thank you for being here, of course. Most welcome. It's a pleasant surprise. Stella is one of the senior most palliative care professionals in the whole country, usually part of our faculty. Thank you for being here.
I will also do this course, sir. Every time I'm teaching, let me hear something new.
Oh, you a compulsive learner, I can see. Okay. Here are the key messages that I want to convey during the day. One, palliative care is for serious health-related suffering. That is not from an official definition. The official definition of palliative care by WHO is 20 years old. It came out in 2002. Many people have felt the need for revision. I'll show that definition to you. So we'll use this wording from a Lancet Commission report 5 years back, that it is for serious health-related suffering. And as mentioned in WHO definition also, suffering can be physical, mental, social, and that should include financial, especially from the Indian point of view and from the low and middle income world. Financial suffering is enormous, and spiritual suffering. As the third point, I have put in a phrase that palliative care is everybody's business. It is not only for doctors and nurses and social workers and others. It's not only for professionals. It is something to be done by Shweta, Harsharan Kaur, Surekha, Murugan, everybody, every one of us has something to do. We said it is multidisciplinary. We'll explain how volunteers can help later. This is something that we'll remember. A global declaration called Astana Declaration of 2018 includes this message that I put in as number 4. This is for all healthcare. Healthcare has to reach people where they are, when they need it. That should be our target. You should know that a significant number of people, the most needy, the people who need support most, do not get to healthcare institutions. They don't get to hospitals. They are too vulnerable. They do not have the money. They do not have the access. And they live miserable lives and die miserable deaths in their own homes, receiving no care at all. So, Raj Singh, Surekha, we should aim to reach them where they are. Gina, Pennsylvania, we should, Eben is what you call yourself, okay. Chaitlete, we should reach them where they are if they can, especially when they cannot get to us. And ideally, we should be reaching them when they need care, which we are not able to do now, but that should be our ultimate objective. And here I have added one, item 5. Aishi, Tanika, you may be volunteers. You may be receiving no remuneration. Okay, Tarun. Nobody is paying you. You are doing it out of the goodness in your heart. But that does not mean that you don't have to be accountable. When we go there to help people, Ivan, Pratap, Chamundeshwari, you out of your goodness of heart are going to go out there and help people. But still, you have to equip yourself with adequate knowledge. We have to follow the ground rules. We have to follow principles of ethics. That's what we mean by accountable. If you see somebody and because you feel the empathy, you tell them, okay, I'll come to you again on Thursday. Remember, you may be the first human being to show empathy to them since they have had the illness. Empathy is not so common. Even loving family members may not have empathy. They will all be saying, why don't you eat? You should be eating well. Instead, that trying to understand that the person has no appetite. That's something you can do. So with all the empathy, you promise some things. And then they are waiting for this angel next Thursday. And if you don't turn up, Kriparao, Rutu, Pushpa, if you promise to go there and you don't go there, what an abandonment will be there. For the last 6 days, they have been thinking, there is at least one person who is trying to understand me. Now, even that person is deserted us. Imagine the despair. I'm not saying this as part of theory. These are things that I have seen. I've seen the tremendous amount of despair that can cause by a broken promise from somebody with empathy. But we are human beings. We may not be able to get there on Thursday. But if I am not able to fulfill my practice, I have the responsibility. At least ring them up and tell them, I'm so sorry that I am unable to keep my promise, but I'll come. I'll come. If at all possible, I'll come on Friday. If not, I'll come on Monday. That much is absolutely necessary. So this is what I mean by accountability. Accountability is to the people you are trying to help and also to an organization that you are part of. And we'll follow core values. Many of these things I have only sketchily mentioned. Over the next 45 minutes, I'll go into all that in greater detail. Vishnu Sri Priya?
Yes, sir.
The timing is still 6:30, right?
Yes,
Yes,
sir.
sir.
Okay, thank you. So shall we, friends, go by this definition? As I said, this is from a Lancet Commission report. Palliative care is prevention and management of serious health-related suffering. This woman has an advanced incurable cancer. It is in our country, the vast majority of cancers end up being incurable because we are unable to give them timely, effective treatment. But her pain and suffering most of the time are avoidable. It should have been prevented and whenever possible treated. Serious health-related suffering, I would like you to remember as the catchword. This is what we are treating. And remember, I already said, this suffering may not be pain. It may not be even any physical symptom. It may be intense emotional distress. It may be caused by broken relationships or the suffering of a person who feels, oh, my God has deserted me. All that is what we are trying to understand, empathize with, and whenever possible, relieve. You and I are human beings. We cannot relieve every problem. We know that. But whatever we can relieve, we relieve. A lot of people, as I said, suffer without any health care in their homes. You don't even know the depth of their suffering because we all live protected lives. Till I came into palliative care and actually started doing home visits, I myself did not know how much people suffer. I am from a village, yet I did not know. When I started visiting people like this in their homes, only then I saw the extent of suffering they have. Their suffering is huge. But the suffering of the rich, especially with advanced incurable illness, is even worse. Because this man has to suffer the ravages of the disease. This person has the additional suffering inflicted by isolation, a tube into the most sensitive part of the body, the respiratory tract, a suction catheter going in, causing added excruciating suffering, which is unbelievable. And when the person in suffering tries to pull out the tube, hands and feet are tied. Every minute feels like a year of suffering. Do you know of National Cancer Grid? National Cancer Grid is a collaborative of more than 250 cancer institutions in the country. And they have created guidelines. Anybody who wants to look at it, Google for Choosing Wisely India. And one of their guidelines is, do not treat people with advanced metastatic cancer in intensive care units unless there is an acutely reversible event. This is the oncologist conglomerate's advice, Choosing Wisely India. And they also recommend early palliative care. But it is flouted in hospitals over the country. Friends, Kamali, if you tell me, choose between one, either this or that, I would rather have this kind of ending to my life rather than this. I know I'm not saying all intensive care is bad. Don't misunderstand me. I was an intensivist myself. I know that intensive care can dramatically save lives in very serious illness. Minute-to-minute monitoring, minute-to-minute interventions. If the cardiac output drops, your inotropic support starts the next minute so that other organs are saved. But in unsalvageable conditions, it is a horrendous infliction of suffering. During the week, I am sure you will hear more about it. But shall I stop for a minute and see if you have any questions? Would you either unmute and ask or put it upon the chat box?
Sir, Dr. Mobabat has raised his hands.
Yes, please.
Thank you very much, sir. Dear colleagues, I am Dr. Hassan. Thanks for
Can
the
you
session. And
speak a bit louder or come closer to the microphone?
Okay. Oh, yes. Okay, sir.
Okay.
Actually, it is my pleasure to meet with you, sir, today. I used to know your name from internet, and that's
Thank
how I started searching for Pallium India. I'm already learning a lot since you started lecturing. Just a suggestion or a knowledge from you, if I may ask you, sir, like death with dignity. How can it be understood, sir, in palliative care?
Yeah, I am sorry. What was the name? I did not quite see you.
Sir, my name is Hassan. My surname is Dr. Hassan. Hassan, yes, sir.
Dr.
I
Hassan.
stay in Africa. Yes, sir.
Oh, I see. Okay, Dr. Hassan, pleased to have you with us. Welcome, honored guest. Dr. Hassan, you have seen these two pictures. If these people are dying, I see myself in them. I know I am not immortal. I will have to go someday. And by my age, I am closer to it than all of you. But when I go, what I mean by life with dignity is, well, death with dignity, Dr. Hassan, is life to the last moment of life with dignity to the last moment. That's what I really mean. Though we say death with dignity, what we mean is living with dignity in your last few days or weeks. So if this gentleman has to have dignified life till the end and dignified dying process, one thing, he should have his pain relieved, other symptoms relieved. He should not be pouring out pus and having such foul smelling pus that his children don't come near him. He shouldn't have to hang his head down in guilt. I have destroyed my family. Even my home will be lost. My wife and children will be out in the streets. What kind of life has mine been? I wish they could be saved. He should be able, even at this stage, able to sit up, holding his head high. Life with dignity means not only freedom from those elements of suffering, but also receiving love and giving love more than anything else. There is no dignity in an end like this. I'll consider it the greatest blessing if at that time, as I go, I reach out a hand and a friendly hand will meet me. I hope I'll be able to say a final message of farewell to my wife and children. I hope I'll get a kiss on my cheek from my grandchildren. That will mean life is full. Even with all my incapacities at that time, I am a valued human being. So, Dr. Hassan, what we need to do is to make the people valued, make the people dignified, make the people loved. That would be life with dignity and death with dignity, as I see it. I am not quoting from a textbook.
I do get you, sir. Thank you very much. Your description gives me a lot of peace in my mind, sir. Thanks for the description.
Thank you. Anybody else?
Sir, we have a question in chat box from Vaishali Ghosh. Actually, a difficult question. Who makes the decision for a patient whether to go to the ICU or not?
Vaishali, do you have an answer of yourself?
I don't have an answer because I think this is something that we come across a lot. And it's very difficult for the children or the family sometimes, and they want the person to live on longer. I think it's a big dilemma that crops up. So I really wanted to know what you think.
Later on in the session, if we ever get to it, we may not. I have put in this core value, number 1. Who is the most important person, Vaishali?
The patient, yeah.
Patient, the person. You have the answer to the question in yourself. It is more than anybody else, that person's decision. But if the person is able to take a wise and dignified decision, the patient has to be empowered with adequate knowledge. Not as he's, see, Vaishali, what happens much too unhappily frequently is on the last possible day, a head comes out through the door of the ICU, and the family is asked, he will die if you don't put him on a ventilator. It will cost 30,000 rupees per day. Are you willing? And the family is then emotionally blackmailed to saying yes. The patient has no say because he is too ill to take a decision. Wrong. Vaishali has asked a very important question, and all of us have to remember this answer. It may be your loved one in that bed. Your love may be a selfish kind of love, where you say, I can't live without my father. Doctor, do anything to save him. Do anything. And the anything for the doctor is infliction of this kind of suffering for the last 3 weeks of the person's life. If it is an unselfish kind of love, you would be thinking, I don't want my father to suffer. We will do what is best for his well-being. I know his life cannot be saved. I want him to feel comfortable. I want him to be loved. And so, Vaishali, the person's decision is most important. But for that, we'll have to start communication early. What happens very often is I am the patient. I would be too ill. I'll be unable to speak. I may be delirious. I won't be able to take a decision. And legally and ethically, then the decision falls on the family. And family, I said already, if the family should not be confronted this in the waiting room outside the ICU, these are conversations that we should start early. But if at all that has not been done, I am seeing the person outside the ICU. It wouldn't be just my head popping out of that door and asking them. I would come out, ensure some kind of a privacy, sit down with the family, empathize, say, I realize that this is the most dreadful time of your life. But I do have to bring this up. Your dad's condition is such and such. I think the best course of action now is to do things to improve his quality of life. I believe that desperate measures to prolong his life by a few days or weeks will only prolong his suffering. So Vaishali, the answer is shared decision making. Shared decision making. I'll repeat once more, shared decision making. The patient's autonomy comes first. If the patient is unable to take a decision, the family has to be involved. Even otherwise, the family has to be involved. The medical person has to provide the information, empower judgment, wise decisions. So shared decision making is the answer, with the patient at the center of care. Vaishali, is your question answered?
Thank you so much, doctor. Thank you very much.
Vaishali, you asked a very important question. I am glad you asked that.
Yeah, I think it came up because of our personal experience where the family did not agree on the same decision. And I think even with the doctors, some doctors don't give you the full picture and the ICU becomes the first place. So it is I think the question came from that personal suffering of seeing our father being very ill and yet his life was prolonged. So but I loved your answer where you said that the conversation should start before. So I think that is something to keep in mind, definitely.
Vaishali, is he no more?
No, he is not anymore. No.
Vaishali, I'm sure everybody in the group is now feeling a bit of your pain. Many people here have gone through that pain. Dinesh has, Murugan Ambiga Vishwanathan has said, my mother was a cancer patient. Dinesh, I'll answer your question later. I will be coming to that. But in the meantime, Murugan's comment is an answer to my next question. Sri, will you please tell everybody what to do about the poll?
Sure, sir. Right now, we'll be launching a poll and you'll be seeing one question in your screen. So you just have to choose the most appropriate answer and submit.
You mean click on the appropriate
Yes.
answer? Yes. Element of suffering that can be associated with healthcare. Sri Lakshmi, maybe before the course ends, we should start a process. Please make a note of that, where people are encouraged just to share their stories. It can even be audio or video recording or written down things. I think this will be a precious information sharing between people. Thank you for proving the point that this is not about somebody else. This is about us, every one of us. I'm going to show you the WHO definition of palliative care. It's very long. I said it's 20 years old. WHO itself decided to revise it. Unfortunately, the process was stalled and it has not happened yet. But this is I'll show it piece by piece so that the important points are made clear. As many of you said in the beginning, it's about quality of life. And as I said earlier, not only the person with the illness, but also the family. Both are important points. Quality of life, families. Facing the problems associated with life-threatening illness is what WHO said. This is one thing that particularly warrants revision. What is life-threatening? For most people, it is something that will shorten life. But maybe I'll ask you, I am going to stop sharing the screen for the time. What is life? Is that a crazy question? Is it just existence? Is it just a beating heart on a ventilator in the ICU? Don't you in between say, Anita, Archana, ये भी कोई जिंदगी है? This is also life. This is not a life. When life is devoid of any enjoyment, of any contribution, any love, it ceases to be real life in our minds. It is just existence. So, friends, I will request you to think of life in the broader sense, something that holds meaning, enjoyment. If you define life like that, this is okay. A person with a paraplegia, paralysis below the waist, may be confined to four walls for a lifetime in our country. Is that life? Their life is threatened. They are living, but their life is threatened by four walls. So please use this phrase in the larger sense of the term. Some people use in the chat box, you mentioned the word life limiting. That also may carry the same problem with what life is. What is limited? Is it only the lifespan that is limited? So to improve the quality of life of patients and families with life-threatening illness, what you do is you prevent and relieve suffering. Key phrase, suffering. By means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychological, social, and spiritual. Quality of life. Don't forget family is suffering. Life-threatening illness in the larger sense of the word. Prevention and relief of suffering, pain, other symptoms, psychological, social. I mentioned earlier, this was created by Westerners. When we talk about social suffering, we have to include financial suffering, catastrophic health expenditure, destroying families in generations, and spiritual. Spiritual, when I use the word, and or when the word is used, it shouldn't be only in the context of God and religion. It should be about life being meaningful. It's about having meaningful connections also. Anybody has a comment to offer about the definition? Stella has put in a comment on the chat box. As I said, Stella is a very senior palliative care professional and teacher. Has taught people all over the country. She says, before knowing palliative care, my dad wished to die at home. I agreed with that, and he passed peacefully in the midst of his beloved family. Thank you, Stella. Thank you for contributing that important point. I have a word to add there, Stella. Home is the best place for end of life and death, provided you have somebody to offer palliative care support, at least over the phone. You were there for your father. That made the difference. But if, like that man whose picture I showed, somebody is in the village feeling breathless, unable to take in air, and no support is given, that's not a compassionate end. Sachin asks a little about spiritual suffering. Sri, Vishnu, can you please make a note of that? There was another thing that I said I'll address
Sure,
later.
sir. We have taken a note of that. Dinesh has asked.
How are we
So,
doing for time?
Dr. Hassan has raised his hands.
Yes, Dr. Hassan.
Thank you very much, sir. Again.
Louder, please, Dr. Hassan. Closer to the microphone, please.
Okay, sir. Thank you very much. Thank you very much, sir. Okay, sir. The definition WHO 2002, as you mentioned, sir. My discussion, I read this aspect. If a person is already.
Vishnu, I'm sorry. Something wrong with my audio.
So same here, Dr. Hassan. Can you speak very close to the mic?
Okay, sir. Can you hear me now?
Yeah,
much better. Sir. Much better.
Okay, thank you, sir. So in the definition, sir, like an approach that improves the quality of life of patient and the families facing the problems associated with life-threatening illness through the prevention and relief and suffering, and the rest is fantastic, sir. But my question is, sir, one thing is confusing me, sir. Like if a patient or a person is already facing the life-threatening illness with the family, so how will I prevent it, like in palliative care? Because the prevention part, new.
Yeah.
Thank you.
So, Dr. Hassan, thank you for the question. Very perceptive question. Let me give you an example. A lot of people, say with prostate, lung, kidney, etc. cancers, spread to the bones, right? And very commonly, they affect the thoracic spine, vertebral column. You notice that. You notice that and provide palliative radiation, a single fraction radiation. That will prevent paralysis in future, most likely. See, many people go through paraplegia or paralysis below the waist because of metastatic cancer in the spine. That's an example. Somebody with a lung cancer. Pain is only starting. Again, a palliative radiation may be the best way of relieving that suffering. But it's also about looking for problems well in advance. We have a patient in our inpatient unit yesterday, and I specifically asked him, is your sleep comfortable? Do you have unpleasant dreams? And the man said, silly of me, but I actually feel at night that somebody is trying to kill me, and that wakes me up. It's only an unpleasant dream, but this is what we call hypoactive delirium. Appropriate medication will mean tomorrow terrible hallucinations can be avoided, worsening can be avoided. So preventive measures may be treatment measures, early searching for problems and identification and appropriate action so that worse suffering is prevented. Dr. Hassan, have I answered your question?
Thank you very much, sir. I do get your point, sir. Thanks a lot.
Friends, shall I go on?
Yes, sir.
Oh, am I stuck again? So here is another poll for you. Sri?
Yes, sir. Launching the poll. So just choose the most appropriate, which you feel is the most appropriate, and this. Just one question.
When should palliative care start? As I said earlier, there may be important points with each answer. My personal choice is the first one, at onset of pain and other suffering. Please remember, palliative care is something that should ideally happen along with treatment of the disease. I repeat, ideally, palliative care should start along with treatment of the disease. We, Sri and team, have been doing courses for oncologists. About 60 oncologists from various parts of the country have done a palliative care course. So when they see patients, they'll be doing palliative care also along with their practice. I don't know the number, but pulmonologists have done this. Neurologists have done. More than 75 neurologists in the country have gone through palliative care course. So palliative care is not only done by palliative care specialists, it's not only after end of life. But official definition of WHO has a footnote. It says it has to start at the time of diagnosis. There is not so much a difference between 1 and 3. So that's okay. But ideally, it should not only be after curative treatments. It should go along with that. Sometimes the disease may get cured by 9 months of chemotherapy and radiation and surgery. During that time, also suffering needs to be treated. And certainly, friends, 2 people have answered this. I accept that at the end of life, it is particularly important, but palliative care should not be reserved only for the end of life. When my time comes, why should I go through suffering for 1 year and wait for relief only when I am dying? So, thank you for taking part in the poll. Answers 1 and 3 are acceptable, but it should not be only for the end of life. Thank you for participating in that. I am glad we did that so that the confusion was cleared. Now, this conglomeration of physical, social, emotional, and spiritual aspects of suffering. Hey, wait a minute. Who was the founder of the palliative care movement in the world?
Sir, is it Dr. Cecily Saunders?
Yes, Saunders, Cecily Saunders. I have put up the full, not the full name. Dame is the canonship given by the Queen. Dame Cecily Saunders was the person who founded this, and she herself came out with the concept of total pain. You see that each of these circles is encroaching onto the others. Physical suffering will cause all this a little bit. Social issues will cause a little bit of everything. So remember that each are worsening the other. Each is worsening the other. Of course, what is very often strikingly visible would be the pain or other symptoms. This man, when I saw him for the first time, long time back, he had been in this position for more than 3 weeks, most of the time, with multiple bony pains. And it was less than 15 milligrams of morphine given by small bolus doses intravenously. And in 1 hour, he sat up after 3 weeks and had his first cup of tea in 3 weeks. Remember, pain can be overwhelming, occupying every bit of your mind space, leaving no space for anything else, no space for thinking. You can't take wise and intelligent decisions. These things have to be treated before you ask for consent or anything. What's the point when somebody is unable to think? So physical symptoms, though I mentioned these are all important, often physical symptoms are the one uppermost, not necessarily most of the time. But total pain is all of these together. Sri is going to show you a video now. It is a 7 minutes video, at the end of which I would like your reactions.
Sure, sir. Casting the video.
In palliative care, we have this notion of total pain. Pain
Friends, as you were watching the video, by the way, that is Smriti Rana. Sri, is Smriti doing a session for them, do you think?
Sir, not finalized yet, sir.
Okay, okay. Smriti Rana is a psychologist by training and an important member of our team. And this was during a TEDx talk that she was giving in Bengaluru. I always use this to demonstrate total pain. Earlier, I said pain, total pain is a conglomeration of all this. In this man's social issue of poverty, children's education, causing him emotional and spiritual suffering, where actually worsening is pain. And therefore, we have to deal with all this, including the spiritual issues, specifically because, I'm sorry, who asked this? I forget. This question came up as we were, you were watching it. I quickly put together this video, this slide. Spirituality is about everything that is not material. Let me ask you, why are you all here? So many of you. What do you achieve by being here? Sri?
Sir,
I just wanted to make sure that I am audible.
yes, sir, I think they are just collating what all they could say, sir, because there might
So
be
you are
many.
all here, friends. You will not get more money because of your palliative care training or palliative care work. You have no material gain. It will not bring you a big car. It will not bring you a house with a swimming pool. Yet you are here. You are looking for something more than the material things that will add meaning to life. Spirituality is about all this. What connects you to this world? For a lot of you, it will be God and religion more than anything else. There are people who give up everything to God. You take care of it, cancer or whatever it is, your wish. But it may not be so for everybody. For a lot of people, it's more about relationships, having the family around you, having loved ones around you. And I've seen people in the last week of life wanting to talk to long lost friend living in London. Rebuilding connections, relationships, the tree outside the window, that may be very important for the person. If we have time, which I suspect we may not, we'll try to get Stella to talk about why her father wanted to be at home. It could be all of these. It could, spiritual suffering could be also about feeling life useless. If I start thinking, why am I here? I'm only a burden to everybody. Life holds no meaning. I wish I were gone. Giving a purpose in life can be very important. Like sitting down and asking, tell me the story of your life. With the time that you have, think of something that you will enjoy doing. Some people may want to go to a temple or a church or something else, or a mosque. A lot of people stop. I had a patient whose biggest sorrow was that he could not kneel down, a Muslim patient who could not kneel and pray 5 times because he felt himself unclean. He needed a religious leader to tell him that that's not important, that God will still hear him. So giving a purpose of life, if possible, will be important. But if there is no other purpose of life, remember this. Give them love. Make them feel wanted. Convey the impression with your eyes and face and maybe a touch that you are important to me. These are the various ways in which you make a spiritual assessment and support somebody. Unfortunately, very often, there is a huge disconnect between the medical establishment and the isolated patients. That's where, ladies and gentlemen, you all come in, because you are going to form the meso element of the social capital. Social capital is the product of human interaction with shared values. The patient in the hospital is disconnected from the hospital. The patient alone at the home is disconnected from the whole world. We as members of the community rebuild that connection, make the person feel bonded. Would you believe that this thing that looks like a chicken hoop was the home of one of our patients? We still look after her after 4 years. She was blind, had a diabetic foot where amputation had been suggested above knee. She was a single parent of a 12-year-old boy. This shack was not a home that she could live in really. And on Sunday, her son said, "Mom, I cannot stand this hunger anymore. Let us kill ourselves." The community helped her. We could not solve the enormous problems. We put out a call through social media. Even now, she is living in a rented house. She doesn't have a home of her own yet. But for the last 4 years, the rent is paid by a supporter who lives in UAE. The community brought in the support, and she had a so-called bystander so that she could get her eye operated, retinal surgery. After 4 years of blindness, she saw her son again. You think you cannot help as a volunteer to help somebody regain sight? You're wrong. What was necessary was already there. The hospital was there, the surgery was available. But she did not have somebody to go to hospital with her, somebody to stay with her. The community made sure that she had a paid caregiver to stay with her in the hospital. The community paid for her treatment of her diabetic foot in a diabetic center so that she started walking again. I see Shravan, I saw you only just now. You have seen the book Walk with the Weary. And on the cover page, there is a picture of a woman and a boy. Their faces are not visible. This is they. This was the story. A lot of people came together to make her see again and walk again. They felt her feel supported, conveyed that you are important. We care for you. They looked after her social and financial issues as much as they could. The community gave her love, connected her again to this world. She was totally disconnected from this world, connected her again. And we now together are her family. When you talk about spiritual support, please do not think only about God and religion and prayers and incense and chants. It's also about human connections and love. I wish I had more time to spend on it, but we do not. But we look after children's education also. At the moment, Palliative India is supporting the education of about 400 children who would have possibly dropped out of school because a parent is dead or because a parent is ill. And also not only educational support, even recently, they have the group arranged a get-together for them. These children already have very black and white lives. We make sure that they have some fun, a get together, some ice cream, some good food, some games and play. All that is important for a child's development. From the group of children we have supported, now we have doctors, many engineers, many other professionals, teachers, so many categories of people. And some of them are working with us as nurses now. So I'll stop there by mentioning the core value, the first core value that I wanted to talk about, that is the patient first and the family second are the most important considerations. Pallium India, Sunanda, Vishnu, Sripriya, Pallium India is not the most important thing for you and me. It is the patient and the family second. No organization should grow bigger than the cause. Yes. And we should remember that these people in any civilized society, they deserve the care. It is a right. No, they are not begging for you. They shouldn't have to beg. If we are decent human beings in a cultured society, we have a responsibility to look after the less fortunate amidst us. Care shouldn't be a charity. You are getting something. I am getting a lot. What I am getting is meaning to my life. They are giving it to me. I am obliged to them. And compassion is not enough. Competence is essential. Thank you for attending the program, which makes you competent. Simple things. The attention to the hand washing. Without that, you will be killing somebody with a dreadful infection carried from one patient to another. In every way, even in communication, we need competence. We shall try to do the right thing for the right reason as best as we can. Competence cannot be forgotten. Compassion is not enough. We recognize the value of every one of you, every one of us, the social capital, the essence of goodness in the community. And meaningful and complete care is impossible without this partnership with the community. Most importantly, not only for palliative care, this is for the whole life of everyone. Tamsu Benla, Chai, everybody, please Archana, please remember, this is for lesson for life. Every one of you here is superior to me in some way. I know that. I don't know in what way. I don't know you, Archana, but I know that you have something in you that I do not have. And that makes me treat you with respect. Savali, once we start treating everyone else with respect, our relationships improve. Sometimes I may forget because I'm a doctor and that arrogance of that degree and stethoscope around my neck may make me arrogant. If I treat anybody with disrespect, I'll be quick to apologize. And finally, autonomy. The person having most right over himself, beneficence, doing good, non-maleficence, not doing harm, and distributive justice. Equitable allocation of available resources. These are the core values that we will hold. Autonomy, beneficence, non-maleficence, justice. So this is what we try to achieve. Our organization envisions. Why are we saying India? By the registered charities focus, it is India. But really, we should all be aiming for a world where palliative care is integrated into all healthcare, that every person has access to effective pain relief and quality palliative care, along with treatments across the continuum of care. That means from the beginning of the illness to the very end. And here are the key messages that I believe I have conveyed. Palliative care is for all serious health-related suffering. Suffering can be physical, mental, social, and spiritual. Palliative care is everybody's business. We all have something to do in this. We have to reach people where they are, in the shack of that woman with the blind and the woman. We have to reach them. And the fact that we are volunteers, you and I are volunteers. I am also a volunteer. But we cannot forget accountability and core values. I have less than 10 minutes left for questions and answers. I'm sure there'll be a flood of questions. But quickly taking a minute, Stella, can you tell me, as far as you know, sorry to rake up painful memories, as far as you know, why did your father want to be at home? If you know.
Yeah, I knew, sir. No, the first and foremost thing was he was suffering from COPD, diagnosed. So every now and then he was taken to the hospital. Of course, I was not here for a long time. So twice he was put in ICU and he never wanted to be in the tubes. So once he was out of ICU, he knew that nothing is going to work out now. So when he came home and when I came back, he just told me only one thing. He said, I want to just die at home, surrounded by all my beloved ones. I just don't want any tubings on my body. I just want to go peacefully. So you be at the bedside, you look after me. That's all I want. I want. So I just agreed with it because he had undergone that pain of injections, that IV cannulations and everything. And he never wanted that. Even he knew that no treatment is going to work out on his body. And he was a person, I should say, he was a badminton coach. He was a national player who was always on the center of the people, where finally he found that these things are not going to happen. I was really happy when my dad told me that he doesn't want to go to the hospital. Even to the last minute when he has collapsed and my mom told, come on, we will take him to the hospital. He just took his finger and he said like this, no. He said, I want to be here. And the same day, the whole 12 hours, the next day he passed away. But we all were there, all grandchildren, all were there surrounded. And it went peacefully. So that pain, so that is the thing. That pain which caused him in the hospitals, that he never wanted to go through that pain.
Stella?
Yes, sir.
Everybody here shares your pain. These memories are difficult to live with. And as Stella's grieving smile will tell you, the loss is forever. The pain will always be there. But Stella is able to remember that with a smile because she could do the best for her dad. Related to that, Stella, Ashwin asks, if the person is adamant to stay in his home, like your dad, but a village without medical aid, how can it be a dignified death? So, Ashwin, unfortunately, that is the state of affairs for 96% of people in the country. Ashwin, this is something we all have to change. But in the meantime, what we have done is started a telehealth service. Any one of you can ring up our telehealth program. Sri Priya, would you please put up the telehealth number on the chat box? And we'll, from a distance, we'll do what we can, which is sometimes very limited, sometimes quite a lot. Ashwin, this is the reality. Thank you for pointing it out. But let us resolve that we all will do our little bit. Dr. Hassan from Lesotho, you have a question or a comment?
Sir, thank you very much for sharing another participant here of dad's story. And it is not uncommon, which you have just mentioned. A person can choose not to go to ICU. He or she can feel, instead of being surrounded by those monitors, CPAP, the ventilators in the ICU, rather than I will be surrounded by my loved ones at home in my last days of life. I think that opinion of the patient should be respected, and it was well respected in that case which you just mentioned. And it is also seen in this side of Africa. I can just a small note I can share with you, sir, and others. One prostate cancer elderly patient was diagnosed CA prostate with Gleason score 9, and he was supposed to send for radiation and then bilateral orchidectomy. But he and his wife chose not to go for the specific therapy like radiation and also surgery. Rather, they suggested the team of palliative care here in my clinic to that they will stay home, but they will come for like when we explained what is palliative care, they said, okay, we will take this treatment, palliative care here, and being at home, we will not go for radiation or surgery. Thank you very much, sir.
Dr. Hassan, are you a medical doctor, Dr. Hassan?
Sir, I am running the palliative care facility in Lesotho. I'm the one who started here in 2018, sir.
Okay.
There was no
Dr.
palliative
Hassan.
care at one point. Thank you, sir. So I interested to learn from your team, sir.
So here is an expert who should have been a faculty member attending the course. Dr. Hassan, thank you for being here.
You're welcome, sir.
With the limited time we have, Sri, would you agreeing to extending the session by another 5 minutes to take on some questions?
Sure, sir.
So we have a question in chat box from Mr. Dinesh.
Yes.
Do I have to be in a hospital to receive palliative care? That's the first question.
Thank you for asking the question, and how remiss of me not to have made it clear. I showed you the picture of the social capital and how the community gets together. Shouldn't have. People should not have to travel to hospitals to receive palliative care. Palliative care should reach them in their homes. In our institution, Trivandrum, we have 14 beds for inpatients. We are looking after more than 4,000 patients. We have 7 home visit teams going out every day, caring for very ill people in their own homes. People should be treated in their homes as much as possible. That's the ideal. India will take a long time to get there. I suppose Dr. Hassan in Lesotho will have a long way to go before people get palliative. Everybody who wants it gets palliative care in the home.
Sir, Dinesh has asked another question. Can you please brief the details of psychological support for palliative care?
Sri, we will have a session on communication, and that will be covering psychological aspects, Dr. Dinesh. So I would rather leave it to another session because it cannot be answered in a sentence or two. It's about understanding the person's frame of mind and dealing with it appropriately. We will deal with that during the next few days.
So Dr. Sachin has asked, can you please explain a little about spiritual suffering? I think you have highlighted a bit about that earlier.
Again, during the course, during the communication session, it will be attended. But let me. So sorry, who asked that?
Dr. Sachin.
Sachin, let me tell you what I actually do. I had a patient a doctor's mother, who went on saying, I wish I could go now. What's the point of my being alive? I'm not good for anything. I'm unable to do anything useful for the family. And the doctor said, you don't have to do anything useful. Just take rest. That doesn't help. The person is feeling that there is no purpose in life. I would sit down with the person, close enough to lay a hand on the hands, if I have the opportunity. And I may say, tell me about yourself. Tell me the story of your life. And friends, try this on your own parent or on your own grandparents. You don't know them very often. Say, Dad or Mom, tell me about your childhood. And so many stories will come. As people tell their stories, what is important to them will come out. We'll feel what connects them to this world. We will know their faith or lack of it. If they don't believe in a conventional God, it is not my job to push God down their throats. That's okay. They will have their own values. It is to understand them. By my action of sitting down and listening, I am always also conveying to them, you are important to me. I care for you. This comes from my heart. If I am just acting, it wouldn't carry any meaning. Every human being is my teacher, especially when they are at their very ill. They share such a lot. During the conversation, I will find, let me tell you, one man, I said this, okay, with the time that you have, he knew it was a very little time. Is there something that you want to do? Somebody whom you want to see? Somewhere you want to go? You won't believe it. He wanted to go back to the school where he had studied. The man had only primary school education. We persuaded the sons to take him on a Sunday. The man traveled by more than 1 hour by car to the school, walked around the classrooms holding his son's hands, talked about his childhood in the school, and as he was returning, he told his son, I am at peace now. The man was reliving his childhood, maybe the only happy time he had in his life. And that reconnecting with the school was important to him. Many people want to go on a pilgrimage. Many people want to see a priest or a religious elder. It is up to them. But connecting them to what is important to them and adding meaning to their lives, making them feel valued and loved. These are essential elements of spiritual care. In an intensive care unit, I have a lot of respect for nurses, but at one time, I defied a nursing superintendent who was preventing a priest from entering an ICU for giving a last communion to a patient who demanded it. I just opened the door, took the priest by hand, and took him in to see the patient. And that was very important for him, for those to whom religion is important.
So we have a couple of more questions.
Suppose, Vishnu, we compromise by taking 2 more questions, and I promise you to make the answers short enough.
Okay, sir. So it's a general question from Salina D'Souza. Are doctors advising patients and relatives to avail of palliative care? I think that's a general question from.
Sorry. Can you repeat the question?
Are doctors advising patients and relatives to avail of palliative care?
Who asked that?
Alina D'Souza.
Alina, most of India has no palliative care access. And generally, doctors also do not understand palliative care. India has 1.2 million doctors. Only about 5,000 of them would have had palliative care training, such a tiny percentage. So this doesn't happen today. Alina, no sense in mourning about it. We'll have to do something about it. And what we will do is to talk about it, write about it, help development of palliative care centers. And never underestimate yourself. What you can do can be tremendous. Sri Priya, also share my presentation with everybody, okay?
Sure, sir.
Sir, as promised, 2 more questions.
Sri and Vishnu, Vishnu,
yes,
you please give this to Apurva. And
sure.
Sri, we have a directory on our website. Okay, just Google to Pallium India and look at the directory and give the link on the chat box so that Apurva will have answer to her question. State by state list palliative care centers are listed.
Yes,
Ashwin, youngsters have a lot to do. In Kerala, we train school students who do wonders. And college students, they do a lot. They raise funds. They go and visit patients, give them support. Sometimes find out what is necessary and help their lot. What can students not do? What can youngsters not do? The sky is the limit. We already explained that palliative care is not only something to be done by professionals. It is for everybody. And that's what would be my final message. And I'll leave you with this question. Because you have asked that question, I'll bring up this question also. You have to decide, what is it you plan to do with your own wild and precious life? Your life is in front of you. Would you just have bigger and bigger cars to be unhappy in? Or would you bring some meaning to your life? During the succeeding sessions, this answer was very inadequate. I can sense that. What can youngsters do? Maybe one of the sessions, Sri Priya, maybe we'll have to explain about our Sans Pain project, our Students in Palliative Care initiative, and what all students do.
Yes, sir. We do have that topic covered in Mr. Babu's.
Okay, very good. That will be covered in detail. Stella, thank you very much for being here and sharing your experience. The Thailand palliative care is low cost. Sri Priya, please remind me at when I share the Lancet Commission report with them, 2018, Access to Palliative Care. It talks about an essential package of palliative care. And it has made the estimate that for countries, low and middle income countries, the cost of palliative, essential package of palliative care is only 0.6% of universal health coverage. It's very little. Nothing expensive. We don't need gadgets. We don't need huge electronic equipment. It's inexpensive. Palliative care is really affordable, provided we, human beings with emotions and compassion, are part of it. Somebody is asking for the recording of the session. Sri?
It's our duty, sir. We'll provide.
Palliative care? Oh, yes, Tamil Nadu. Many.
Sure, sir.
I mean, next
it's
to
my
Kerala, the Tamil Nadu has the most palliative care centers, Dinesh. Again, our go to palliavindia.org, look at the directory, and you will have the list. Go to click on Tamil Nadu. So this was an active participation, friends. Thank you, everybody, for joining. I don't know about you, but I certainly enjoyed it enormously. Sri Priya and Vishnu, Sunanda, thank you all for being here with us. And
Thank you, sir.
Everybody enjoy the course and find an answer to yourself for this question. What is it you plan to do with your own wild and precious life? Have a great evening.
Thank you, sir. Thank you for that very insightful introduction to palliative care. And we had a true, as you rightly pointed out, we had a very good number of participants, almost 60 participants were there throughout the session. I hope this will continue for the rest of the sessions also. As you highlighted in the very last slide, along with the compassion, we also have to have a competence for contributing to this greater cause. Thank you all. Thank you for participating in this session. Over to you, Sri Priya.
Thank you, sir. Thank you so much. As expected, always a very enlightening and interactive session. Hope everyone would have learned many new points from this session, just like us, because each session with you is enlightening for us as well as your team members, and we are proud of that. So, with the promise that the future sessions are also going to be equally interactive and informative. This is Sri Priya along with Dr. Rajagopal and Mr. Vishnu signing off from the Tips Eco Hub. See you tomorrow with another interesting session. Till then, everyone, take care. Bye-bye.